Great. Okay, so thanks everyone. The title of the journal for today is the C study, Safety, Efficacy and Equity of Implementing Autonomous Artificial Intelligence for Diagnosing Diabetic Retinopathy in Youth, and it was published last month in Diabetes Care. And it's a study from the USA, which has a accompanying podcast with it in the journal, just interestingly. Oh, let me just see if I can click. So just to go through a bit of background taken from the journal, essentially, diabetes, as we well know, is a leading cause of blindness and visual loss in young adults and working age population in the UK. They present in their intro that there's a risk of development and progression of retinopathy, obviously with diabetes, mitigated by well-known factors such as intensive glycemic control, hypercholesterolemia, etc., etc. And thinking about the glycemic control, only 17% of paediatric patients achieve targets. I don't know why I can't seem to click, I'll keep going. And evaluating for complications, including diabetic retinopathy, is obviously important as a way of detecting and intervening to prevent early visual loss. And relevant to the USA, they quote the American Diabetes Association guidelines and say that they recommend in their most recent guidelines screening for diabetic retinopathy in patients with type 1 diabetes within 3 to 5 years of diagnosis, and at the time of diagnosis for patients with type 2 diabetes, with annual follow-up thereafter. But actually, studies show that around 35 to 72% of young people with diabetes undergo the recommended ophthalmic exams in accordance with these guidelines across a number of different studies and literature. And understandably, the prevalence of diabetic retinopathy in youth is low, but it's likely to increase with the rising incidence of paediatric and adolescent diabetes, particularly type 2 diabetes, and therefore an earlier onset of diabetic retinopathy. And they present that recently autonomous artificial intelligence systems built for early detecting diabetic retinopathy have recently been included in the ADA guidelines screening for adults. And that actually builds upon a previous paper by the same group. We'll talk about that later. So just thinking about some of the adherence issues, this is a study from Wang prior to, sort of quoted in this particular study, that actually ethnic minority youth and children from lower socioeconomic backgrounds are less likely to undergo recommended screening. And this is a graph taken from the Wang study in 2017, which included 12,000 youths with diabetes, 5,500 with type 1, the remaining with type 2. Just really showing that difference between the white Asian populations and Black Latino. And some barriers, of course, there'll be multifactorial, like any barriers in long-term conditions, but poor health, forgetfulness, lack of health insurance, thinking about the US perspective, financial barriers, lack of acceptance perhaps for the diagnosis of diabetes, length of time spent with all the multiple appointments that ensue, including ophthalmic examinations and time off, etc. So that's just thinking about some of the pre-existing literature, looking at the barriers.
That's saying at 6 years, there's a significant difference, yeah?
Indeed,
because
yeah.
it's about 40 versus 60% at 6 years. Has that ever had an eye screen?
Yeah.
Right.
Yeah. So we know clearly that detecting diabetic retinopathy progression is key. This is just a nice, pretty image just to show some of the pathology and the fact that we know that factors like pro-inflammatory cytokines, VEGF, a well-known factor, may be implicated in some of the new vessels that ensue. Just a reminder, more for me than anyone else, really, just to really go through the different stages. So mild, non-proliferative diabetic retinopathy with microaneurysms, then thinking about the moderate non-proliferative diabetic retinopathy with microaneurysms, hemorrhages, cotton wool spots, proliferative, all in the name, with the new vessels, potentially at the optic disc, some hard exudates, and then thinking about diabetic macular edema with the hard exudates of the fovea. And obviously that need to enter a diabetic eye screening program, to be invited to it, and then to continue on that trajectory as appropriate. And just because this is a short journal, I just want to pad it out and just think about our own eye screening program, just again, more for me. So Peter Scanlon sort of wrote about this, sort of a historical view on how the diabetic eye screening program ensued. And it was based on the following principles of screening. So I'm not going to go through them. We all know what principles of screening are, but there are obviously issues with screening, that some people may be harmed by the process or falsely reassured, the ethical, moral responsibilities to have high quality programs, and that underpins our national program in the UK, in England, and the quality assurance of screening programs, just as a bit of a reminder. And in 1995, at one of the diabetes meetings, the consensus view was put forward by the diabetologist that a screening test for diabetic retinopathy should have a minimum specificity of 80%, and a minimum sensitivity, that is, sorry for the typo, of 80%, and a specificity of 95%. And this, again, is just a screenshot through our own national diabetes eye screening program of patients being invited to attend eligibility confirmation. They get invited, they have their screening event, the grading pathway, and all of the various parts. I won't go through that in too much detail, but we can later. This is a much easier version. So screening is offered every year to people with diabetes, so type 1 and 2 in our country, aged 12 years or above. Each person should get at least one invitation and a reminder. They have their visual acuity, they have a dilating agent applied, they have digital photographs taken of both retina. There are 2 photos typically per side. Images get graded by human graders for signs of diabetic retinopathy and maculopathy using the RxMX grading system, and then screening results are sent to patients and their GP within 6 weeks. So that's just a bit of an overview. But actually, I think just key points for thinking about the important elements for a pathway like this that is, highly successful in England, is that sort of excellent training of the human graders, providing primary, secondary and arbitration grading, the intense training that ensues, the quality assurance that needs to take place, having a clear plan for patients who need that more frequent monitoring, what happens to them in surveillance outside of the routine pathway, having all images with referable disease reviewed by the clinical lead or a designated senior grader to decide a referral outcome grade. So this is just a bit of a Mickey Mouse tour of what happens. Sorry. So with the rising prevalence of diabetes, of course, there will be workload challenges when we think about the human grading elements and all of the parts that make up an excellent quality assured screening program. So there is a bit of a movement towards more artificial intelligence enabled algorithms. Certainly a few years ago from Moorfield, there's a AI system called iArt that's been used more recently in adults. So, there is beginning to be momentum for this particular technology, and diabetic retinopathy is one of the exemplars potentially. And it would be useful in a setting where trained workforce are unavailable or rapid results are needed. Anyway, so moving on, back to the journal. What was the purpose of the C study? To prospectively assess the diagnostic efficacy of the autonomous artificial intelligence for diabetic retinopathy screening in paediatric and young adults in a real-world setting, and to then measure the adherence to ophthalmic screening guidelines before and after that implementation. The location of the study was a multidisciplinary paediatric diabetes clinic affiliated with Johns Hopkins in the US. They received an IRB approval for the study in accordance with the Declaration of Helsinki. The inclusion criteria are patients aged between 5 and 21 years of age with type 1, 2 cystic fibrosis related diabetes who are being seen for their regular routine care in that real world setting over a 1-year period. They excluded patients that had ophthalmic abnormalities like media opacities, so, there is or strabismus. In terms of going through this approach, so basically patients and their carers were notified by an electronic messaging in advance of the appointment that they would be approached for this particular study. On the day of the appointment, a trained research assistant and also the operator of the AI sort of camera approaches them at the appointment. Once they consent, they basically have a non-mydriatic, so no dilation, fundus camera installed with the AI IDX DR AI. And there are 2 colour photos taken per eye of the retina. And then they go on to have their normal diabetic appointment with the specialist. The AI images, so I think the point to make here is if there is insufficient quality of the images at this point in the journey, there is a real-time method that the AI informs the operator that they need to take some more photographs basically there and then. The AI images are interpreted using an algorithm to identify whether there are no changes to the retina, whether there's mild diabetic retinopathy or more than mild diabetic retinopathy. So those images get uploaded onto an electronic note system, and 2 retina specialists, i.e. ophthalmologists, review these findings, and they're masked obviously to the AI findings. And the 2 retina specialists interpret the images using the International Clinical Diabetic Retinopathy Classification System, which has sort of no changes, mild, non-proliferative, moderate, severe, and proliferative, a bit like those images I showed you earlier in previous slides. So thinking about the, sort of just looking at their reporting, so they approached 327 people, 17 refused for reasons like lack of time, already had an eye exam, or a legal guardian wasn't present. 310 agreed to participate. 8 of the imaging was insufficient, so there was insufficient output, so they were excluded. So there were 302 patient images available for review, of which, of the 302, 235 of them were negative, i.e. there was no or mild diabetic retinopathy, whilst the AI interpreted 67 of those 302 images as positive, as in there was more than mild diabetic retinopathy, these 2 sort of categorization. And in terms of the final numbers, and we'll go into that in a bit more detail, of the AI positive, i.e. there's more than mild disease interpreted by the AI algorithm, actually 6 ended up having a final diagnosis of more than mild diabetic retinopathy. And then thinking about the negative ones, so of the 235 that were deemed to be negative, so actually no or mild disease, that rang true. Actually, only 1 of those patients of the 235 went on to have that rated as more than mild diabetic retinopathy. Go into that in a bit more detail. So just thinking about the characteristics of the study population, very few figures in this paper, to be honest with you. There's not much that's being said in this table, so I will just summarise it. There are 310 patients who participated. Obviously, 302 images were sufficient. Of the study, the full study population, 54% were female, 57% were white, 82% of patients had type 1 diabetes, 70% of them had a HbA1c that was below the target range. The mean age at diagnosis for the full group was 8.9 years, standard deviation of 4.4, and the median duration of diabetes until this particular point in time for the group at large was 2.52 years. So going through the screening results. So overall, the prevalence of diabetic retinopathy in the population was 4.2%, and that is comparable to other studies of adolescents with diabetes. And type 1 diabetes around that same number, a bit higher than type 2. The diagnosability, as they call it, using the AI images, as in enough with sufficient quality to make that diagnosis, was 97.5%, the 302. And when comparing the AI interpretation to the reference standard, i.e. the 2 retina specialists who are reviewing these images, the sensitivity of AI to detect more than mild diabetic retinopathy was 85.67%, and the specificity of AI to detect more than mild diabetic retinopathy was 79.3%. And they went on to do these adherence corrected sensitivity calculations as well, which basically some calculations to say, would some of these this adjusted calculation, would this ring true in the population of patients who are non-adherent to this, who weren't screened as well? And we can talk a bit about that later, but it didn't really change anything all that much. Then thinking about negative predictive value, that was 99%. You can see here 234 were negative, 1 ended up having a more than mild diabetic retinopathy when reviewed by the reference standard. So
that assumes that the reference standard, the person doing it never misses a case, because there is also specificity for humans, which might be lower.
Yeah.
But we haven't got a gold standard. That is the gold standard, so that's what we're...
Yeah, we can talk about, yeah, exactly. Is that the gold standard? And is the gold standard people, or is the gold standard the diabetic retinopathy severity scale that you're using? as well. So these retina specialists use the International Clinical Diabetic Retinopathy Scale, whilst a lot of other sites will use the ones from previous studies, which are considered to be the gold standard, and we'll talk about that again.
I could have set the gold standard as the machine and then seen how specific and sensitive the graders were. Do it in reverse.
Yeah.
It would be interesting, wouldn't it? Because
it would be interesting. Yeah. And the positive predictive value was 9%. And there was no adjustment. So if you take the group of people who would have been screened by the ADA anyway, had they gone and attended, that would be 149 patients. That didn't really change the positive predictive value and the negative predictive value all that much. Okay, so let's just go into what's going on. So thinking about the false negative retinopathy screen, that is, somebody was falsely reassured. So they've put into their paper some images of that particular patient, of why they were falsely reassured, because there was a missed isolated retinal hemorrhage in this nasal region that was missed, essentially. Thinking about the false positive, so in this particular paper, just going back to it, hold on a moment, just get that right, 61 patients were thought to have more than mild diabetic retinopathy by the AI. And actually, a large proportion of those did not, obviously. So there were things that they picked up. So there was this thing called shiny internal limiting membrane, and they show you some exemplars of this, where the AI, because in sort of younger people, there is a more prevalent internal limiting membrane, it could be mistaken for hard exudates. And that was the case, most likely in 44 of those cases. Then there were quality issues. So there's diffuse reddish hue that may have changed how it was perceived. Maybe it sort of gives an impression. They didn't actually go into that in any more detail, but maybe the AI is picking that up as new vessels. I don't know. There was an edge artifact. And then they went on to try and think about these 61 patients where the AI had picked up them to be falsely positive, as in more than mild, and did univariate and multivariate analyses to say, well, is there some increased false positive rate by age or gender or ethnicity? And indeed, that was not the case. So that is an issue. They also looked at inter-rater agreement between the graders, our gold standard people, which was 92.2% with a weighted Cohen score of 0.2. Some other factors they report very descriptively in the results. There's no sort of visuals for this, but they say the attempts to capture an image by AI at that point of care test was achieved in 60% of patients within one attempt. And then the remaining, there was several attempts to get an appropriate image. The average imaging time for the first 40 patients involved in this study, and obviously one would expect things to get a bit quicker as the operators become more experienced, was 7 minutes, 13 seconds, and then it improved a bit to 6.5 minutes, thereafter. And I suppose the important thing is adherence improved in this group of patients from 49% pre-intervention to 95% after AI.
What does that mean, adherence? Means they came again? Or?
Sorry, can you repeat that?
What do you mean by adherence?
Adherence?
Yeah, I mean, they're there.
To eye screening.
Yes, but they've come for eye screening. You mean again, another time? What does that mean?
They didn't, exactly. And that's the point. So that's one of the key things that they bring out in the abstract, in the podcast as well, which I've listened to. It's one of the selling points, but actually they didn't follow them up for a long period of time thereafter to see what they did. So I'm not quite sure how they've come to that conclusion. They've looked at the patients who would have been eligible for ADA screening.
Yes.
Said that it's gone up because they would have referred a number perhaps as well, but it's not clear how they've come to that. But that's one of their sort of take-home point.
I mean, one of the problems with that statement is, does it mean that with a bit of research you get much better attention? Because obviously there's a study, you get phone calls. Is that what they mean? I mean, it's not clear that it's due to the AI.
And it's not dissected out as to how that is the case. When you read it, you think, well, it's just improved because you've given them a test, and maybe a lot of the more than milds have gone off to have some proper eye screening.
Yeah.
But it's not very transparent about that part. So I think all in all, this non-dilated fundoscopic camera use in the real world MDT clinical setting as point of care does show a sensitivity of 86% and a specificity of 79% compared to the retina specialist, which we'll deem as gold standard for now. The diagnosability, as in appropriate images accrued, seem to be high. And also that AI system will inform the staff member operator if the images are inadequate anyway. This bit about increased adherence improved from 49% to 95% with this point of care test. Again, not clear, but that's one of their take home points. So let's just go through the strengths. Of course, it's a real world clinical setting study. I always personally think that's a strength because we see what it's like when we think about complex interventions, etc., in a real world setting. It's prospective, and there are a large number of AI studies doing this sort of thing in diabetic retinopathy in adults on a retrospective basis. So of course it's a strength. It's a point of care test with rapid real-time information. So coming back to that point about how it's been compared, so it's been compared to the 2 retina specialists who hopefully are in agreement, who are using the International Diabetic Retinopathy Grading System versus the complex early treatment diabetic retinopathy study. So the ETDRS was a landmark study back in the late 80s, which essentially showed us that scatter laser is an important thing, and macular, it sort of set clear outcomes. So when if you use a severity scale that was sort of described in this landmark study, then it is a surrogate for outcomes, basically. So it was an intervention study, but actually what's come from that study is also what is thought to be the gold standard for many decades of how you grade diabetic retinopathy. And in this particular study, the retina specialists didn't use that, they used this other grading system. So that's just a point to make. So is it a strength, or could I really be putting that in a limitation? It's probably a strength because this is thought to be quite complex in real world settings with a lot of retina specialists not really using this. Well, I'll show you images on how that's done anyway in a minute. The strength of this study is also avoided misclassification. So earlier studies have used just a single human grader when you look at AI images and stuff. So we've got 2 people here, and then if there's some discrepancy, a third specialist opinion is sought. They've also looked at intergrader variability, which seems obvious, but a large number of studies haven't done that in the past. And I suppose from this, they've looked at age, ethnicity, gender, and that doesn't seem to influence the AI image interpretation. Limitations is small n numbers, obviously. Diabetic retinopathy has a low prevalence in this paediatric population, sort of that 4%. So you do need your n numbers to go up to really be able to understand if the AI is a useful tool, I think, in this particular.
There were 300, weren't there?
302, yeah.
That's quite a big N, isn't it?
Well, I mean, if you compare it to adult studies of 14,000.
Oh, I see. Okay, yeah.
So the same group published in Nature, one of the Nature journals, Digital Health, I think.
Right.
And they had like 12,000 or so.
Right.
So, and it's using the same AI algorithm. And that's what made it into the ADA guideline, that you can use AI in the adult, so as care. So it's much larger. And also that shining limiting membrane problem doesn't seem to be a problem in the adults as much.
Right.
So yeah. Anyway, and this study, again, mainly type 1 patients, unsurprisingly, if they're young. And there's no information on the AI approach. And admittedly, I didn't have it about me to go back to the original paper and really understand their AI technology. I probably wouldn't have understood it anyway. So what they do say is that actually we need to do some multi-center larger studies. True. They need to think about their reference standard a bit more as well. So for instance, in the 61 more than mild diabetic retinopathy patients, sure, there's this limiting membrane thing happening, and the retina specialists have deemed that the retina are normal, so it's less than sort of more than mild, if you know what I mean. But actually, maybe there is some subclinical changes, and maybe using OCT imaging might show some early there. So they're planning to look at OCT in subsequent studies, and even think about using it as an RCT approach, using AI versus the traditional screening methods, but no further information on that. So I'm going to go back to the National Diabetes Eye Screening Programme. Just you can ignore this, it's just the stages and considerations that were required in the development of this particular programme, which is a success. So I want to just list the stages to say, well, obviously it was a well thought out process, which is working at a national basis with quite high sort of adherence and recall rates and so on. And in the National Diabetes Eye Screening Programme, what they do is they take 2 images per eye, and they have based it on the early retinopathy study that I was telling you about earlier, that landmark study. So in the landmark studies, they take these 7 different fields around the disc, so 7 different fields, and at least you need sort of 1, 2, 4, 6, 5, and 7. You sort of need this area at the very least to be able to grade the retina. So when the National Diabetes Eye Screening Programme came about, they initially started thinking, do we dilate people's eyes or not? How many images do we take? Do we go the whole hog, like that landmark study, and do the 7 fields to be really precise? Or can we get away with 1 or 2? So in Scotland, for instance, they use non-dilated fundi. They do a single image, and if there's an abnormality, they recall them and do a dilated exam. On the English National Diabetes Eye Screening Programme, 2 images are taken in these regions, which roughly sort of you just have to believe me with my moving mouse, you can see it, overlay to part of that. And anyway, going back to the point, so this 2-field mydriatic approach has a sensitivity of 87%, 87.8, and a specificity of 86%, which compares, thinking back to the AI study I've just described, the sensitivity there was 85.7, oops, sorry, and the specificity was 79%. Okay, so to conclude, the point of care AI retinal screening may improve screening rates, sure. You're definitely going to increase accessibility. Hopefully that does improve equity and addresses some of the hard to reach groups. The sensitivity and specificity are comparable. So the ADA, when they approved the adult AI retinal screening, said a sensitivity and specificity of 80% for both is the threshold. So it's not far off. Sure, it's exciting, it's, you know, it's sexy when you have AI and so on, but it's probably not the same as an ophthalmologist, clearly. They have shown it's safe and effective. They've got some real-time results. There's no need for sort of dilating the eye up and so on, but they clearly need more studies. And I suppose the point is in this group of patients who are, you know, for multiple reasons, it's difficult for them to attend, is sort of trying to have perfection the enemy of good? As in, should we, you know, if something's not happening at all and they're not having a photograph at all, is this something which is not perfect, at least, you know, better than nothing? So in practical points, you could see how this might work in a GP practice diabetes centres with the validation. You'd clearly need to have a bit of a brief. If you're being given real-time results from AI, you'd need to take a bit of a brief eye history if something's come up. In conjunction with that, that might delay clinic and so on. Clearly, it's not as good as an eye specialist, and maybe this is not appropriate for older patients where it has been approved, where actually that eye visit will allow you to, you know, monitor intraocular pressures for glaucoma and so on. The high false positive from this study would obviously add to the burden of anxiety, and that is comparable to other studies with some high false positive rates. But I think, you know, this area is definitely becoming an area where, you know, adoption of AI into clinical use and guidelines, you know, it's very promising. And with that, I'm not going to read this out. It's just a parting paragraph about caution with AI and the differences between sort of diagnostic decision making. I shall stop there.
Yes. Well, it's interesting you said it's not as good an ophthalmologist. It might be better in that last slide. I mean, if you miss something, you miss something. And that's a very human trait. And if you look at someone's eye or look at a photo and you don't see it, you miss it, and then it's gone. And the machine might be more sensitive and specific. I know there's a risk that it's less sensitive now, but when they get it right, when you said point of care, what does that mean? Did the machine, was it mobile?
Yeah.
Unlike the photographs then, so the mobile would, can I just check this? So the machine would go to the patient and then the patient later would be screened.
No, that machine was sitting in the clinic, basically.
Oh, that's not, point of care means you go to the patient. So if the patient's at home, you go to their house. Is that like a BM stick? I mean, I just want to know how mobile it is.
Well, I don't know. It was sat, from my understanding, it was sat in clinic.
Okay, so it's not really point of care, because if it is point of care, that will really increase uptake, because you can wheel it into the general practice or wheel it into wherever.
It's scalable, yeah. So I mean, the same instruments being used in GP practices in the US.
Okay, and then the other part of the study with the traditional thing, was that also mobile, or do you need to go to somewhere else? That's why I haven't worked out.
So those images from the AI were uploaded onto the patient's electronic records, and then the retina specialist would just review them that way.
Oh, I see. Okay. So it's not.
Sheba, I think. Oh, sorry.
Go on.
Sheba, that was really interesting, and I think you presented it really nicely, just going through the history of the program as well. So thanks for that. I think this is a really weird study. It's like they're trying to see what else they can do with this technology. As you say, it's small numbers in a population with virtually very small prevalence of diabetic retinopathy, and if it is there, it's unlikely to be changing. I think Kareem's point is correct. I think AI is likely to be superior to an ophthalmologist in the long term. And some of you will know this thing that's always quoted in AI literature, that actually machine learning algorithms can identify gender from a retinal picture. And they get it 100% of the time, and no human eye can detect what it is about the retina that differentiates male from female, but the AI algorithm has recognized it. So I think in the future, it's very likely that the AI algorithm or the machine learning algorithm will be superior to ophthalmology. I think the problem here is the training data set. So you have to train a machine learning algorithm, as you know, and it sounds like they used the adult training algorithm. So basically you train AI, sorry if I'm recapitulating what you know, but you say, this is retinopathy, this isn't retinopathy, and you give hundreds of thousands of images. And then you can break it down and say, okay, this is R1, M0, R2, whatever. So that's how you train it. And then, so the training data set is one of the most important aspects of this. And if they've just taken the adult training data set and applied it to children, then it's likely to be less sensitive, because as you've pointed out, there are some changes in the pediatric retina that are probably not present in the adult retina. So it's all a bit weird.
It's a bit weird. I think they were just trying to get it approved, and it's one of the sort of the penultimate author is an employee and one of the sort of managing directors of the IDX, or DR AI. I should stop sounding so cynical all the time, but yeah, they are.
Yeah, you have a point, but I mean, it's got its uses. The other thing is, can it obviously it can compare your last retinal screen. If you screened 2 years ago, what AI can do better than a human is pixel by pixel look for differences. And that we can do that too, but it would take time, and they'll be really fast for that kind of thing.
Yeah, there's no mention of sort of a comparison.
But that would only be valuable if we had something meaningful to do, right? And I think when technologies like this make it into routine practice, we have to ask, like you did, Sheba, what is the value of that in the entire process? So if we pick someone up with R2 or R3 earlier, we need a study to show that earlier detection resulted in meaningful improvements for it to be worthwhile.
Yes, I mean, part of that comes from the fact that people don't come. So I mean, you're right. If we pick it up earlier and then we've got to wait till it's significant before we intervene. But if they're picked up at all, I mean, the end point, of course, is blindness for some unlucky people. And if we can pick it up, it's not a question of early. It's not like cancer where you've got to pick it up early, but it needs to be picked up at all, because I mean, some people present very late, don't they, with proliferation.
We don't even screen people under 12 here. So it's only after the age of 12 that they enter the screening program. So it's just quite an odd population to study.
Yeah, I know. Wide age range as well.
I mean, you're right. It does sound a bit like a marketing thing, because, of course, they need different. You do this kind of thing when you want to apply for a license to get something passed in a different age group. And pediatrics is always an important age group to get approval through. But still, I think it's really important. And yes, thank you for informing us about this. Because the next time you look, you'll find that you're not required.
Yeah.
No, you're a machine there.
Brilliant.
Oh, I think, Alex, have you got any thoughts? I can see you put your camera on.
Yeah. No, I was just going to say that I liked Sheba's and Shavana's comments about that they're trying to fit AI into everything, and they're trying to fit it into reading CT scans for osteoporosis as well now, and vertebral fractures.
I mean, radiology and any image is something that AI could. You're right. They're finding a use for it.
I'd be worried if I was a radiologist, I think.
I wouldn't be worried. I would use it as a friend. I wouldn't be threatened. It's very important to not feel threatened. You've got to use these tools, and there's enough work for everybody. Honestly, I wouldn't say, oh, we wouldn't do that. That would be Luddite.
If it's shown that a computer can spot the abnormality on a CT abdo-pelvis better than a human,
yes,
okay,
but if
you need humans to supervise it, but you won't need that many humans.
Well, the problem is, of course, if it finds all the thyroid nodules and makes people have biopsies, we need to put the specific part of that is really important.
Yeah, but you can train it to work out which nodules end up being the cancer ones, and
that's what I would do. So I would use it.
Yeah, but you need less of them. I don't know.
Okay.
I think we're okay in endocrinology. I think you can machine learn endocrinology.
Oh, you'd be surprised. Don't feel smug.
Okay.
Especially osteoporosis. You just need a FRAX score and you're out.
Yeah. I won't reply.